I'd like to begin with Medicaid expansions. And first question is, if you look at the waivers granted to states in conjunction with their expanding Medicaid, what can be gleaned about potential changes to the nature of the partnership between states and the federal government for Medicaid?
I'm not sure. I'll try a crack. I'm not sure exactly, what the question refers to, but it's been pretty stark with the waivers that are granted, and I think the New York Times had this really very visually powerful map of what's happening among the red states and the blue states and where the lion's percentage of the uninsured lie. I mean, clearly within Obamacare, the Medicaid expansion has been the most successful, and to the extent that these states have been given leeway to seek a waiver and not participate, they're likely to continue to do that. I think for us on the street, we were probably, at least I was, initially about Florida in particular expanding Medicaid, and it looks like even that seems to have stalled, and we'll have to see what happens after the elections. And as far as Texas goes, I'm not that optimistic even after the elections. And those are the biggest states where particularly the for-profit health hospitals that we all cover have a geographic presence.
So I have a very cynical view. I doubted that Florida would expand, although there was a moment of brief hope when you thought that maybe the Arkansas plan was the solution, the politically acceptable solution in Florida, and that lasted for about 3 split political seconds. And Texas ain't never going to happen. The probability of Medicaid expansions, I think, diminishes as we get closer and closer to the fact that the government's 100% subsidy of the additional cost drops to 90% in just a few more years and goes, away to a greater extent after that. So, the time to really take advantage of the federal government's largesse from a state perspective actually has passed, in my view, to a very large extent. And I've actually cautioned some of the hospital companies who talked very optimistically about future expansions on the calls, on the third quarter conference calls, as they were holding out, some measure of hope to investors, that, when those subsidies go away, we've been through, for example, an FMAP cut of that, we had that increase in the recession and then the 10% went away. And that was absolutely brutal in terms of what happened to Medicaid spending and hospital reimbursements. And so I don't think anybody really wants to live through that again, either from a state political perspective and a state governance perspective or a hospital perspective. I think that CMS really tried to bend over backwards as much as it could to facilitate the participation in Medicaid expansions, as it should have, and pretty much would have approved anything reasonable. For example, something as quite interesting and innovative as the Arkansas plan. Now we're at risk with the election in Kentucky, for example, a plan that was implemented by a governor overriding a legislature with a new Republican governor overriding his predecessor. So if anything, I think we're going to take steps backwards in Medicaid expansion, not forwards. And just a footnote on Texas and Florida, 20% of the state of Texas remains uninsured as of the last Kaiser Foundation survey. I think before, when we started, it was maybe 23% of the population in Texas was uninsured, so virtually no progress made there. It is a big state, and 3% is still a lot of people, but virtually no progress made there. Wall Street is amazing in its naivete and willingness to invest without knowing what it's doing. There were many people who owned hospital stocks who were shocked to find that the ACA didn't cover every living soul in America with insurance, that magically everyone would be covered. And so when HCA came out and said, yeah, our uninsured volumes are increasing, they're up 8, 10, 12, 13%, depending on the moment you looked at it, year over year, guess what? There's still a big chunk of the population that remains unchanged. And with very little prospect to be getting insurance anytime soon.
If I could speak up in behalf of the naivete, I just with a slightly more optimistic view on Medicaid expansion. and this is seat of the pants, but first of all, if you think about what might happen, let's say if the GOP wins in November, I would think you'll go to a more federalist approach on health reform, where states that have already expanded Medicaid will be allowed to keep that, if you will, because I think that's going to be pretty difficult to unravel. And you might see something like block grants for the states that have wanted to stay out of the Medicaid expansion. At least that's one possible outcome. On the other hand, if the Democrats win, I think you will see more states fold into the Medicaid expansion than not. The comments recently, I think it was from the Alabama governor, Republican governor, expressing some level of interest in pursuing the Medicaid expansion. That was sort of
that was interesting.
A crack in the iceberg. Yeah, I agree with you. We'll have to watch Kentucky. So that's my view on the situation.
So when you say the Democrats win in November of this coming year, a year from now, do you mean not just the White House?
Well, I think I'm trying to put it in simplistic terms. It could be more than the White House, or maybe it's the current configuration in Congress with Hillary in the White House.
Yeah, I think nothing gets done on healthcare. I think nothing gets done in that circumstance. But that's all right.
Yeah, I got to agree with you, Sheryl. I mean, if you look at it, there hasn't been a political penalty to pay at the state level. And in fact, the GOP's taken more of the legislatures and governorships, by not expanding Medicaid. So there hasn't been a political penalty to play. And I think, like you said, Kentucky's going to be very interesting to see what happens there. Whether or not they can take away those benefits. Yeah. And what the political price is to pay there, if there is any.
This is somewhat of an aside, but I was amused when conservative critics of the Supreme Court criticized Chief Justice Roberts soundly for his support of the ACA. And what they don't understand is that he did more to eviscerate the ACA by allowing the court to not enforce the Medicaid expansion than anything else he could have done. Because it's the only thing that's working. B, it was the simplest approach to ensuring the most people. And C, it's led to the persistence of vast numbers of people being uninsured.
Sure. Mm-hmm.
And I guess a question from me back to all of you that are on the Hill, with the Texas Medicaid waiver and the Florida low-income program, why did CMS and HHS not take a harder line around limiting that funding? I mean, we had two governors obviously come in and threaten the lawsuits and so on, but is there actually any teeth to that? And why couldn't more? I think some of the Medicaid managed care CEOs seem to think that a harder line should have been taken, and they could have driven them in.
Yeah. Well, probably as a parallel, Anna, to the grandfathering and grandmothering of the existing individual plans. In a sense, it meets a short-term political need, even though it sacrifices the long-term goal of the policy.
It's part of the frustration with CMS is that there's not a persistence in a line. They draw a line in the sand, and then they very quickly erase it and step back from it.
Yeah. Let me ask about kind of a basic question. Maybe, Jim, you should start this. Actually, Sheryl might also. In those states that have expanded Medicaid, take us through how this affects the bottom line of hospitals, that they're going to have more paying patients, but they're going to be paying at low rates. Okay?
What we've seen is the main benefit on the not-for-profit side has been a very sharp reduction in charity care. I mean, there's a large portion of this population that's now covered under Medicaid, so at least they're getting reimbursed. I mean, those people were presenting themselves at the emergency room and coming in for care, so that the hospitals were providing that care, but not getting any reimbursement. And so, what we hear quite a bit is that, well, at least now I'm getting reimbursed for that. I think the challenge going forward is, providing that care. Do you have enough physicians there from a primary care standpoint then to begin to manage that? So I think the initial impact has been very positive. At least they're getting reimbursed. The next step is, okay, how do we manage this population because there you really do need to manage it, because if you just approach it from a fee-for-service basis, you're going to lose money on higher volumes there. And so I think that the trick is going to be, how do we manage that population to keep them out of the emergency room going forward, and getting care when it's an acute need.
And whose job is that going to be, that management job, Jim?
Well, I mean, what you're seeing in many states is this movement towards Medicare, managed Medicaid, and so depending on, obviously this is going to hit different healthcare systems differently. If you've got a large managed or Medicaid population, again, your incentive is to work with those managed care providers to really provide that care in a more cost-effective setting. Medical homes, working on those chronic conditions. I think there's a real incentive for the not-for-profits.
Yeah. So has the ACA, perhaps by expanding numbers, led to an acceleration of this movement by states into managed care for Medicaid?
Yes.
Yeah. So let me just help some folks with the math of why you would take a low-paying Medicaid patient every single day over a no-pay patient. Okay, just saying it that way, low pay is greater than no pay.
Good. In those states conducting demonstrations of managed care for dual eligibles, what's your sense of the takeaways so far, if any?
I'd say, unfortunately, underwhelming thus far. This was something that Wall Street viewed a few years ago as the next big thing, and maybe it will evolve to that from the standpoint of a growth opportunity, given the dual spending of north of $300 billion per year, with 90% plus, or maybe we're a little bit below this now, but 90% or so not in managed care, unmanaged. That said, the demonstration programs have gotten off to a slow start, and the numbers have been disappointingly low. Part of that is related to, I think in many cases, higher than expected opt-out rates, reflecting the inclination of providers who serve that population not wanting to see managed care make inroads, whether that's right or not. The problem then is when you have numbers that are as small as they are in many cases, it's not clear that the demonstration programs can actually demonstrate what they need to, which is real cost savings. So the jury's out. We'll see.
Yeah, Matt, I wonder if this could be a factor. I understand that the plans doing the managed care in that demonstration are Medicaid plans. If they instead had gone to Medicare plans, perhaps could that have helped on this opt-out issue as far as something much more familiar and with broader networks for the beneficiaries?
It's a reasonable question. I can't really offer a good opinion on that one.
Yeah.
I don't know that it's just Medicaid, because United and to some degree Aetna and Humana and others are also participating and have won some of these integrated dual contracts. I think, and just sitting from where I sit, I feel like the challenge has been, when you compare why the adoption of Medicare Advantage and seniors liking Medicare Advantage is so different than the experience in public exchange marketplaces and in duals, it feels like the beneficiaries don't have an adequate incentive in the dual eligibles and in exchanges to continue to participate. And the opt-outs are particularly severe in California, and there the providers have literally, in some cases, very large health systems have taken out full-page ads in the newspapers pushing back and advising the beneficiaries not to be in these plans. And it's not just Molina and HealthNet there. I mean, you do have commercially oriented plans as well. So it may be a little bit of it is a network, but a large portion of it is there any cost savings? Is there any financial incentive for them to stay? Why wouldn't you just be in fee-for-service and manage Medicaid and Medicare and stay in your institutional nursing home forever, and no one's trying to move you into some home setting with social work and all the complexities associated with that?
Good point. Next topic is alternative payment models. I'll begin with asking about the provider perspectives on ACOs and bundled payments. So if someone could characterize how hospitals and physician organizations perceive ACO and bundled payment contracting in Medicare and in private insurance.
I'll be happy to start with that. So I think the reactions range from embracing it from among the most innovative of the provider groups to fearing it greatly and treating it like something that is really poisonous to their business model because it always results in fewer heads in beds. I think that the first year participation in the ACOs and the Pioneer ACOs and some of the others, there was some eagerness and some enthusiasm among the providers to try something new, to have the ability perhaps to capture some of the managed care margins that existed at the time by managing population health. What they found was that when the hospital's at risk, the only way the hospital's going to do well in an ACO is if they can gain market share because they're going to lose patient days if the ACO is going to succeed. And as far as I know, there was only one Medicare, the original Medicare ACOs that actually gained market share, and that was Memorial Hermann. All the others not only lost market share, but they also lost volumes in order for the ACO to be successful. Now, that should have been a trumpet sounding for the hospitals that the way of the world is moving them from filling beds being their operating paradigm. That's not why a successful hospital is going to exist anymore. They're going to exist because they run the ACO and some of the margin of it sticks to them, and they're margin indifferent because they have a vertically integrated network or some other strategy to approach us. On the other hand, there are many ACOs being formed by organizations like Optum and Cigna and Aetna and every other health plan in creation who were specifically excluded from the Medicare ACOs initially. So the one entity around that gets how to manage population health and risk at all was excluded from the Medicare design. Medicare, I'm sure, had their reasons. Congress actually had their reasons. So what you're now seeing with the ACOs is that they're becoming very, very popular, being spearheaded by managed care rather than providers, where they're really ACOs with the physicians and to a lesser extent the hospital systems and the other provider networks, because we all understand that the one who controls utilization still is ultimately the physician. So if the rate of proliferation of those, I think this year Optum was looking to establish on top of the 500 they had last year, another 500 or so this year. They're at about 750 today, so they're getting closer. That's a lot of ACOs. I mean, there's many markets and there's many individual, markets where they want to do that, but there's a lot of ACOs just at Optum. So provider groups view that. Facility-based provider groups view that with trepidation. Bundled payments, so the Federation of American Hospital Systems basically told Medicare, you've never done anything mandatory, you can't do comprehensive care for joint replacement because it's mandatory, is a major policy change, you can't do it. Last night they said, oh yes you can, and they're doing it, okay? So we're putting in mandatory bundled payments for hips and knees, which by the way is probably the easiest procedure to do it for because the process is so standardized and the outcomes are so measurable, right? Roll in, walk out, happy. The smart hospitals are getting behind this. They're understanding that this is the way of the world, so you better get your practice in soon, which is why the BPCI pilot, the Model 2 pilot, has increasing participation in the pilot to this day because you better get smart about how to operate under bundled payments where you're responsible for a long length of the episode of care post-discharge. And again, whether it's being, financially incentivized to change the operating model and the paradigm of running the hospital, or pressured by competition or lack of anything else to do to keep your doors open, hospitals are beginning to figure out that they need to embrace, and I think the for-profits have been way ahead of this, they're beginning to embrace this notion that we are going to be at risk, we better learn it soon, and even though we're going to push back and we're going to fight, The hospitals will be all right because they're the ones who are getting the money first. If the physicians were the ones getting the bundled payment, the hospitals would be toast.
Yeah, I was going to say, I think on the Medicare ACO side, I think that one's, we've seen, there's just been, what were there, 32 pioneer ACOs,
Yes.
and I think they're down to 12 now. And there's been a lot of dissatisfaction in terms of the attribution. You don't know who you're attributed. The information coming back from CMS has been badly lagged. And so, and there on the not-for-profit side, there's been a fairly substantial investment in order to move the organization to manage that care in the ACO. And they just don't, organizations haven't seen that payback. I think also that there was very little, if any, risk adjustment to that patient population that you were getting. And so from a financial standpoint, I think on the not-for-profit side, Dartmouth Hitchcock,
Right.
who's been one of the leaders, said, enough, it's not worth it to us. On the commercial ACO side, I think there's been much more embrace. Now, it depends on who you are in your marketplace. If you're a market leader and you've got good alignment with your physicians, or you've got a large physician group, I think there's more acceptance. If you're a traditional standalone hospital with a community-based physician group, I think that they're much more reticent about that. I think this move towards bundled payment and the move towards ACO, again, is going to be another thing that's pushing consolidation in the not-for-profit space in order to have that size to be able to manage that care through the continuum.
Yeah. And just to follow up on a couple of things, the one thing is I think when I think about how consolidation will affect as a result of all the payment change, and the payment change is massive and it's broad and it's complex at the acute care level and throughout the system. So if there's one underlying trend that Wall Street has missed, it's the pace and complexity of payment change that's going on right now from the private and public sector. But as far as the consolidation we're going to see, it's going to be consolidation in the form of closing hospitals, not consolidation in the form of big mega mergers in the space. Hospital beds are either in the wrong location and must go away and be shifted to the right location, or just simply there are going to be too many of them. The other industry that we need to talk about here is post-acute facilities, because it's not just hospitals. The LeBuhn group did the assessment study for the BPCI after 1 quarter's worth of payment and looked at the preceding 12 quarters leading up to it, but really focusing on the preceding 8 quarters and then the 1 quarter of payment. So this is 1 quarter's worth of data. And while that's a little bit risky, so many of the Model 2 hospitals chose hips and knees that there are more than enough hip and knee cases for the numbers to be statistically significant, and they are compelling. So on a risk-adjusted basis, the skilled nursing facilities saw the percentage of cases at discharge going to SNFs go from 66% to 47%. Okay, from 66% of hips and knees going to SNFs dropped to 47%. Obviously, that was statistically significant. Home health companies saw 25% of discharges coming to them go up to 34, almost 35% on a risk-adjusted basis. So what does that tell you? It tells you some people went home directly without additional care or with outpatient care, which wasn't measured. Some people ended up in home care and, moving from 24% out of every 100 cases, 24 going to 35. Those 11 cases make a big difference in home health. But for a skilled nursing facility to go from 66 to 47, that is huge. Layer on top of that, you have LTAC payment criteria changing. Layer on top of that, you have you have value-based payments going into home health. You have hospice payment arrangements changing. The view of the post-acute care from a reimbursement perspective changing a lot. Then you layer these bundled payments on top of everything. There is going to be very significant shortfalls in heads and beds and post-acute. That's our prediction, my opinion, and significant growth in home health, but the amount of that falling on the bottom line will depend upon how well they do under value-based arrangements.
Yeah, it's very bad news for the companies you cover.
I don't mind delivering bad
Presumably
news.
very good news for policymakers if this payment approach is having real change.
And it did, and I expect it to on a very large scale.
Yes. And talk to me about the capability. There was a simple thing you could do for joint replacement, of just moving people from SNFs to home health, and that made a big difference. What about other cases where you just need the SNF or the home health to perform in more of a population health strategy? Not hold them all for 21 days. Is there much capability in the industry of being a real partner for hospitals?
I think there's some. I think there is some hope there. I mean, there's a couple of entities from the publicly traded side trying to do that, and certainly one of them is Kindred, who in 23 markets has an integrated approach of everything from LTACs to IRFs to SNFs to home health. And part of the challenge there is the math doesn't work, right? If you're getting $600 or $700 a day in inpatient SNF and $150 a day under your Medicare rate, implied $150 a day on your Medicare rate for home health, and you do that math and they're not going to make money, right, when they shift from one to the other. So there are some issues there, but as an integrated provider in 23 markets, they should be a very good partner for the hospital. Health South, for example, in their inpatient rehabilitation facilities, and generally with rehab, because it's easy to measure outcome, can show you really good, solid, significant data over a long period of time that if you send a complex case to them for 13 days, they will save you money because that patient will not bounce back. So there are some partners out there. They've now acquired home health. They are focusing on overlapping their IRFs and home health in the same markets. They're going to stay far away from SNFs. They've already gotten out of the LTAC business, and they're picking their spots. But it's going to be up to the hospital to work with either some notion of a convener or something, or build it internally to be able to pick the right partners and be able to discern what is true outcome data and we'll call it a repeatable process versus anecdote.
Yeah.
So it seems to me in the post-acute space, there's probably more pressure on, heads and beds in terms of skilled nursing, and you're probably going to see a greater divergence of winners and losers. There's just so many, nursing homes that the care is getting taken out of there, and they're going to have to prove their ability to help manage that care, which means lowering that cost.
Let's start with managing the cost. I'm not sure they have any incentive to do that right now, other than their own profit margin, but because it's not really even a case, right, sort of. But the other issue that we're facing with the skilled nursing, because of site-neutral payments up top for LTACs and for IRFs, they're trying to increase their level of acuity so that they can fill the beds with the patients that they're not going to compete with from the LTACs. The LTACs are trying to compete with those higher acuity SNF patients and go for the per diem rather than have empty beds. So what it tells you is there's, in some sense, there's too much facility-based capacity, or the facility-based capacity that you have has to be reoriented in terms of what patients it really is optimal to treat, and that's going to be an extraordinarily painful process.
Good. What about, I guess I was surprised when I haven't seen the details of the joint replacement rule that came out last night, but just from the proposed rule, I was surprised that they were putting the hospital at the center of this. And any comments about, why they did that, whether they're going to limit the potential of it by doing it?
So I don't know the answer because I'm not at CMS, but I could guess that they had really, really, really good data from the BPCI model too, because that's where they got all the participation. And if you're going to put in place a mandatory pilot in a large number of markets affecting a significant number of beneficiaries, you better have data at your back. And that was the model in which the hospital was at risk with the anchor stay and directing us.
Yeah, good point. Other comments? Are many delivery systems deciding not to pursue ACOs? Actually, this was John's question. I said it might be in here. There may be more to answer. Are many delivery systems rejecting ACOs in favor of developing their own limited network insurance product, sometimes in partnership with an insurer, for the Medicare Advantage markets and the ACA marketplaces of private exchanges? So this is somewhat of a return to what we were talking before, but in a sense, do you see evidence of providers making the calculation? You're like, I'm already efficient. If I get an ACA contract, I'm going to have to become more efficient to do well. Why don't I capture that efficiency by, having a contract that's pegged to community experience, like Medicare Advantage or like a plan in an exchange?
Well, if I could just take a crack at this one, of course, when we use the term ACO, it can be used in different contexts with the Pioneer ACO program, which has not had the momentum that proponents had hoped it would, as compared to all the various private ACOs that get announced in various forms and press releases by health systems, by payers that are helping put those together. How many of those are real versus arrangements on paper that may or may not eventually become meaningful remains to be seen. Their new ACO arrangements in that sense are continuing to emerge every day. So I'm not sure we can say, rejecting ACOs, except if we mean the Medicare ACOs, in favor of developing their own limited network insurance product. You're seeing both.
Yeah.
And you're seeing ACOs that are in effect limited network insurance partnerships in partnership with a payer, and then in less frequently you're seeing health systems offer their own products, Medicare Advantage and on the exchanges.
One thought I think that we didn't cover, which I think is maybe obvious and maybe underappreciated, is that when a health system comes in to do a limited network insurance product and underwrites risk, that they put a certain amount of capital, and it's typically, rule of thumb, about 10% of the health insurance premiums that are underwritten is ring-fenced as risk-based capital. And let's even leave apart all the capabilities and the skill sets and, hospitals, and do they have any business underwriting because they're not capable of doing it. At the end of the day, it's capital. And I've heard sort of one of the theses that I get asked about is, in the long run, will we just have a proliferation of health systems that each underwrite in their own limited network insurance product and eventually disintermediate health plans? And I think the truth of it is that we do spend almost $3 trillion in this country, and when you think about how much of that is underwritten premiums at 10%, that's a massive amount of capital that I don't think even exists in these systems.
That's a good point. We've been focusing on providers' perspectives on these payment arrangements, like the terms of plans. In a sense, I guess we've heard some comments that plans are doing a lot of this, private plans. But is this, how would you characterize their interest in payment reform? And also, a few years ago, we used to hear about, when there are dominant plans in local markets, they don't feel much motivation to go into this space. So what does it look like now?
I think plans have always been interested in payment reform. There are two stools to the whole equation of cost trend moderation, and with all of this broader healthcare overhaul, not just Obamacare, the pressure on plans to, quote unquote, prove their value proposition and moderate cost trend is just critical to them. There's an existential risk if they don't, and you have consumerism, and they are stretching the envelope on high deductible plans, penetration, the level of the deductible. But if they don't get payment reform and to some degree start eating away at the physician first and over time into health systems, and then finally, I think even the for-profit hospitals come their way, it's very challenging for them to achieve the next level of cost trend moderation that we've been talking about going forward. That being said, of course, if they work with self-insured employers like Boeing, who may even consider disintermediating them and contracting directly with some of the local health systems, that's not the type of payment reform I think that they're seeking. They're looking for a win-win solution where there is shared risk. They're willing to bring their capital and their balance sheet to bear, and they're willing to bring their underwriting capabilities. And increasingly, companies like United with Optum, and increasingly I would expect Aetna and Humana and the others as well, will bring more coordinated care management processes and tools and technology, and enabling these health systems to underwrite this risk in a calculated and intelligent manner.
Yeah, and if I could just add to that, so if you again make a contrast with the late 90s, when I think what we saw from health plans at that time was many of them were just flat out reluctant to get into fair and supportive risk arrangements with provider systems that were interested in doing that. And where they did, they were often lopsided deals, that weren't adequately supported by the plans. It seems like we're in a different era now, 20 years later, where the plans are really pushing for this to happen successfully. There's an awareness that they can't push too much risk too quickly, that they have to provide a lot in terms of support. And so I think it is real, and there's to some degree a race among the plans to see who can make this happen the most quickly.
Good. And have plans worked out an efficient way of doing this and involving their customers from self-insured employers?
Not really, not yet.
Yeah, so this is an obstacle now,
Right.
because that's about half of their business?
More
the
than
aggregate?
half. Yeah.
More than half, yes. So maybe that's more, what about finding provider partners that they think are capable of being on the...
Paul, if I could just go back to
Sure.
the self-insured employers for a second. This is going to be an evolving area to watch. I think if you went back just a couple of years ago, there was a great deal of enthusiasm that sort of burst suddenly on the scene over private exchanges, and in particular, the hope, perhaps, that you would see a shift start by self-insured employers back into fully insured arrangements as the best way of being in private exchanges, and that this would, bring the whole purchasing system, start to bring it into a structure that would, really support population-based reimbursement for provider systems. And to some degree, it's been a disappointment and a fizzle in the last 2 years, at least relative to how great the hype was. That said, as with many things in healthcare, change takes a long time. If you think about where we are with adoption of private exchanges, not that they provide all the answers, they don't, but we are somewhere around the adoption rate that we were with consumer-directed health plan products back in 2004, 2005. And now, as we saw from the most recent Kaiser survey, those products are adopted by about a quarter of all commercially covered lives in the U.S. And that would suggest somewhere along the lines of mid-decade getting to something similar. If that is going to in fact be the structural change that we see for self-insured employers, it may be something else.
I see. So you're thinking it perhaps through private exchanges, and that I take it doesn't work now to get the permission of each self-insured employer. We have this ACO contract with Hospital A, System A. Is it okay with you that we pay these rates and these bonuses?
I mean, that may work. That may ultimately, that'll be worked out in that direction. We don't know yet.
Okay.
But to answer the question that you asked, so I think there are, generally speaking, a large number of provider systems who are willing to be partners with managed care, either on their terms, which are not the managed care plan's terms, or who aren't really ready to take the risk. And sometimes, as was mentioned, I think by Anna, that the plans have to back away, because if they're going to bring this to the market, if they're going to commit capital and sign up members, they're going to be on the hook for this, and you can't have your partner fail. So since managing populations is a different strategy for hospitals, it's just taking a very long time to build that level of expertise where you can have a dependable, well-functioning market with appropriate protocols for treating these patients that will generate predictable enough results to minimize the risk of entering the relationship for the plan.
Yeah.
I think what's interesting you brought up in Seattle with Boeing. Again, on the not-for-profit side, I think as I think about value-based reimbursement, population health management, particularly the large employers who generally, they have an ASO, they're taking the risk. They're asking the providers and the physicians to take the risk. And the providers and physicians, I think, are sort of looking at that. And if you've got the scale in a marketplace, it's like, well, why do I need to, what's the benefit that, that the insurance company brings? I can just do that direct and then not have to share the benefits with that organization. And so I think you're going to see, again, consolidation. As you said, what I expect is that those organizations that have the size and scale are dipping their toe in a lot of different areas to see where things are going, but they are transitioning to becoming a healthcare company, not a hospital provider.
Yeah. When plans look at bundled payment or ACOs, do they have a preference, or do they think both are worth pursuing, or do you see that one is getting the priority because of seeing that as having more opportunities?
I think Matt would give you the really professional answer of it's really hard to say, and I'll give you, and I'll give you, this is the difference between Goldman Sachs and not, and I'll give you, in a lot of cases, you throw it up against the wall and you see if it sticks, because it's really uncharted territory. You don't know what's going to work, and even if you think you know what's going to work, the marketplace is it's complex, it's fungible, and the incentives are at cross purposes oftentimes that, the hospitals aren't where the plans are, the doctors aren't where either the hospitals or the plans are, and if you don't have all three in alignment, understanding and capable of achieving the same goal, it's not going to work.
Yeah.
One other comment just on these arrangements I'll offer is that the place where we've seen the outcomes demonstrated most strongly has been in the West Coast market, in California in particular,
Which makes a lot of sense.
and not all of the success, but the predominant chunk of it has been with physician-driven models. And so what's interesting about the development of ACOs is in so many markets outside of California, as they've recently evolved, they've been hospital-centered rather than physician-driven. And one can make an argument that's got to change in order for them to be successful. They really should be much more physician-directed. I'm not necessarily endorsing that view as right, although a lot of certainly those California physicians would probably back that. The reason that hospitals have emerged at the center of these new ACOs is because they're the only large organized party with at least some access to capital and systems and economies of scale in these markets that can step forward to do that.
Yes. I'm glad you pointed out California being different in so many ways. And one other difference is that, say for these physician organizations, they have long-standing experience with much greater degrees of risk than an ACO. And they see the ACO as just, we already have the infrastructure. Maybe we can do something in the Medicare fee-for-service population or the commercial PPO population, but we would much rather do this for a higher degree of risk as we have in other populations. Topic on narrow network plans, and we've seen particularly in the marketplaces, and it's probably the case in private exchanges too, narrow network plans taking a very large share. And to the degree that you followed it, to what extent are the networks in these plans being built on low unit prices versus broader measures of spending, like per episode or per year?
I think to the extent we have some visibility on that, it's they're being built more frequently around per bundled or population-based reimbursement mechanisms, although certainly there are some elements of lower unit-based reimbursement as well. The success and traction for narrow network plans is, my opinion, going to depend a lot on how much of the plan selection is at the retail level versus continuing to be at the group level. Having said that, it's interesting, just recently there's been a bit of an emerging trend around employers moving back to slice contracting, large contracts. Large employers moving back to having more contracts rather than, for the last 15 years, it seemed every year it was contract consolidation, fewer and fewer carriers, and now all of a sudden there's a little bit, I don't want to overplay it, but some movement in the direction of more slice contracting. So that's going to be something to watch.
Yeah.
So what we saw originally from what, if you listen to what the for-profit hospitals will tell you, is for exchange contracts and the like, it was a small discount between 5 and 10% at most off of traditional managed care rates, with the hope that you would get a fair amount of the volume from that plan, although I don't think there was any real guarantee of volume because the plans couldn't guarantee volume. They didn't know at the time how many members they would ultimately have, which was, again, if you can't guarantee volume, then it's really hard to negotiate a more creative and potentially innovative contract structure. So from what I see, I think if you were to poll the publicly traded hospital companies, they would tell you that they are seeing an increasing number of their managed care contracts being tied to quality or value-based payments in some way, shape, or form. But I have seen no data to suggest that quality arrangement is a bundled arrangement, but rather it's a benchmark achievement arrangement. You've reduced your readmissions, you've reduced your hospital-acquired infections. Type of, you've maybe improved some outcome measure, and you get a bonus for that, rather than some of the newer, innovative arrangements, but not really tied to a narrow network. It seems to be network construct indifferent.
Mm-hmm. And right now, the value-based payments, they're teeny.
They're teeny.
Yeah.
They're very small still.
It's funny. We talked with organizations. They say, 15% of our contracts are value-based, or 15% of our reimbursement. And then when you ask what the delta is, I actually scratch my head and go, why even invest in it?
That's right. Yeah. And oftentimes what you're doing is giving up on the base rate in order to get it as a bonus later on.
Exactly.
You don't even
there's no
realize it.
downside. Yeah.
Let's move on to large employer health benefit strategies. Of course, that's a really big part of the insurance market. And first question is, to what extent are large employers taking steps now to prepare for the Cadillac tax?
I can take that. Well, I think right now they're just utilizing all the levers at their disposal to manage cost trends down without doing anything drastic like moving out of group insurance into private or public exchanges in any meaningful degree. And so the types of things are the obvious ones. I think high deductible health plans, you're clearly seeing a pretty dramatic acceleration in the penetration, the size of the deductible. They're employing as much as they can more population health management techniques. It works much better in a large employer organization where your insurance company together with you. There's so much data that's available on your employee population to be able to stratify risk and target interventions where they have the highest return on investment, and you can reduce your hospital admissions and readmissions and so on. As we start moving probably into 2017, you might begin to see a little bit more adoption I think, of the private exchange paradigm, though here too our forecasts say that you won't really, this is more evolutionary than revolutionary, you won't really see much major change happen until maybe even, the early to the middle part of the next decade, if you will.
And just to add to that, I think 2017 is going to be the interesting year to watch, of course, because most employers, while they're engaging in planning, they may have made some changes. They're really waiting to see what happens. What happens in the November election outcome next year, and then following that, what happens with policy, what happens with regulation writing, what does Congress do? But we're going to get into a very short time frame for stuff to happen versus, at least for some employers, many of them will not be immediately subject to the Cadillac tax threshold, but for those that are, they're going to have to have a plan and be ready to implement that plan very quickly. And it may be drastic in some cases because they won't necessarily have gotten on a gradual approach to get down to where they need to get to be under the Cadillac tax threshold, because they're waiting to see what will happen. And I think the expectation from many people, if not most, is that the Cadillac tax will be either pushed out or watered down through regulation, maybe even eliminated.
Yeah. Matt, I was surprised about 2 years ago, I think, started seeing surveys coming from the benefits and consulting firms that survey, and we're talking about steps being taken now. Yeah. And I know back then it was probably less uncertainty about whether the tax is going to go into effect, but it was really many years out, which would imply, the importance of avoiding a sharp change just before it went in.
Well, I think just to maybe that's where you were going or not, but these benefit consulting firms have their own incentives around fostering the adoption of private exchanges, right? Because they're always concerned about disintermediation with the public exchange as a channel that might take hold to a greater degree. And in some ways, maybe, as we're discussing the sustainability of the marketplace and its health on the public exchange arena, that might help some of the private exchange penetration. But the distribution side of employer health insurance has so often been the driver of adoption patterns by employers that need not necessarily make fiscal sense. And the whole notion of best of breed, where you still have standalone PBMs and they're trying to segregate each component of benefits rather than have kind of integrated value propositions take hold, are all things that the Towers and Aons and Mercers of the world are fostering.
Good. Before I get into my next question, if anyone has additional questions on blue cards, this would be a good time to write them down. Hospital employment of physicians. How much further will the trend go? Say 5-10 years from now, what are we going to see?
Well, I think we are a long way from being done on that score yet. The losses associated with owning the practices or employing the physicians aren't great enough to cause enough pain for the hospitals to stop. And forgive my cynicism, but I don't think anything changes over time, and I don't think hospitals have become better managers or better aligned with their physician partners and employees than they have been in the past. But it is crucial for them to make sure that they have that, we'll call it alignment, whether it's employment or control over the practice in some way, shape, or form, to be able to manage under, if any or all of these alternative payment changes come. Owning or being aligned with the physician is ultimately crucial for the hospital. And primary care in particular, because as your reimbursement gets compressed, you need to shift the patient into outpatient. You need to be part of that process. You need to have visibility into that process, and you also need to get paid for those services, as a separate source of revenue while you're controlling it. So, I think that as the power base within healthcare shifts to, because doctors aren't going to organize among themselves, and they have to be organized. And so as the power base shifts to larger, more well-organized, maybe not at national scale, but certainly at local scale organizations, and as dealing with managed care companies is difficult and as reimbursement is limited, there's going to be this push up from the physicians and down from the hospitals, and we'll see this continued consolidation until the point of pain comes, and I'm not sure when that is, when we realize that either the payment models that necessitated that consolidation didn't evolve, or they evolved but still don't compensate the combined entity for their combined value, in which case they'll split apart again.
Yeah. Well, I agree with you. I think what we're seeing, there's a lot of competition, at least on the not-for-profit side, for primary care. Yep. Is kind of where it's at. I think for a while there were, it was kind of, well, we want to get the specialists. Now that has worked against some organizations, and to the extent that the hospital can absorb some of those costs to help align incentives, I think that is, right now, that's still sort of the name of the game. And again, it depends on what your market is, why you're acquiring some of those physicians. I mean, we've got some hospitals, and they're kind of the only game in town. They're like, why am I going to acquire my physicians? Why am I going to absorb that cost? I'm not picking up any market share there. I think when we talk with organizations, the younger physicians coming out, we hear pretty loudly they want to move into the employed model. And so we're sort of in this transitory phase where you've got older physicians that are independent practice physicians that want to remain that way, and it depends on the marketplace. As we were saying, in California, it's much further ahead than large parts of the country, particularly the East Coast, tends to be, community-based independent physician model.
But it's even changing in the East Coast. I mean, Summit Medical Group has bought up virtually every practice in affluent Essex County, New Jersey. They can find and avoided every practice in the less affluent parts and not surprisingly, because they can. And that tells you something. They're preparing to do something with that. The other issue here is that it's not just hospitals acquiring physician practices or large group practices. It's also some of the health plans, like Optum, and with mixed success. But I can tell you, it was a real learning experience for United Healthcare, Optum. The Optum part of United Health Group, actually, I should be careful here, sitting opposite Anthem in California with their physician groups that they owned, negotiating rates as a provider. This was a truly humbling and learning experience for them that was probably necessary. But that was part of the reason why they bought those practices, was to learn precisely that, to figure out what was broken.
One of the things that's interesting as well is physician leadership on the hospital side. You really see that in some of the larger organizations. If you look at Providence, if you look at Banner, if you look at Aurora up in Wisconsin, generally you're seeing physician leadership. Those are being run by physicians, and I think it brings that perspective to the organization, and it probably brings some credibility when they're going out and negotiating with different hospital or physician groups, whether it's a full employment or some sort of alignment model.
Yeah, I mean, one of the things I was really worried about as we were on the cusp of reform was this whole question of leadership, and who would be the leaders who would take the hospitals in particular, but also to some extent the health plans, into this new uncharted territory of how to behave under increasing regulation. Not so much the expansion of coverage part, that was the easy part. It was all of the increasing regulation and all of the shift to value-based payments of the world changing around them. Because you saw this wave of retirement of the old, and in the for-profit space, actually, in the publicly traded companies, we've seen some retirement, but not a whole lot. We're kind of in anticipation of some retirements, some more eagerly than others, shall remain nameless, and that's also in part because the success or failure in managing through this whole process. Physicians are part of that, but it's just the overall overarching thesis for the hospitals is right now, physicians fill beds, that's why I want them, as opposed to physicians heal patients, that's why I want them. The most forward-thinking hospitals are buying them because they heal patients. The majority are buying them because they fill beds.
Yeah, so if you can envision, go out 5 or more years, where population health has become more substantial, where the trend of younger physicians wanting to be employed has progressed further. And, perhaps there'll even be a time that there will be, hospitals will decide, I'm really pretty bad at this. I can be better spinning off this group and, aligning with it. Or maybe some of them will be picked up, maybe plans will be better at it than hospitals. But, could you see a world where, the managers of the physicians, it's a competitive process. Who's best at it?
Yeah, I mean, I still think that the trend is towards hospital-based employment of physicians. I mean, if you look at bundled payments, you've got to have the hospitals and the doctors together to who's going to split up those dollars. And so I think, as Sheryl was saying, the alignments, I mean, one of the big problems in healthcare is that all the incentives are misaligned. And I think, over the longer term, obviously there's going to be some bumps in the road because there's still an unalignment of incentives, but you're going to bring that more into focus, I think, going forward.
Yeah.
I just would caution that may be the outcome, but we'll see, because the most successful models have been physician-driven, and frankly, most of the hospitals don't like that model because at the end of the day, they're one of the downstream vendors in that model, as are other providers of services. Mm-hmm. But that's the one that's heretofore shown the strongest cost-effective and cost and quality outcome evidence.
Every clinic model.
Yeah.
I think one of the interesting things too that the recent announcement that CMS is going to pay for when you acquire a physician, one of the incentives has been, or one of the subsidies is, I acquire that physician group, and then all of a sudden I can bill for certain services under my hospital code and get a much higher reimbursement. And they've said, okay, well, we'll grandfather that in, but going forward, no more.
Yeah.
That's right.
Yeah.
So that could
that may be something that would sort of.
In fact, I've even seen in California where in one area there were hospital systems doing joint ventures with radiologists on imaging and and surgeons on surgery centers, and deliberately keeping them outside of the hospital, despite the bump up in hospital rates, because they were concerned they wouldn't be competitive as a system, contracting with health plans, getting into narrow networks. So in a sense, a lot of this is how evolved things become and how competitive the market is, as to, yes, there's a short-term incentive. We get paid a lot more if we hire the physicians, but that could be a liability down the road.
Right. But I think going back to Sheryl's point, that there were maybe some, that was a way to subsidize maybe a strategy there that, maybe didn't make great strategic sense over the long term.
Yeah.
I guess in the end state, though, coming back to a point I think Sheryl made around, capacity shakeout, and this whole notion of filling beds is because there's overcapacity in this whole system. And will we ever get to that, 5-7 years from now, will we get to that end state where the hospital is no longer so overcapacitized that all they're thinking about is filling the beds? And at that point, it's more about the physicians being the ones that are actually treating and healing the patients, as opposed to this whole notion of, referrals driving every piece of their behavior.
Well, one can always hope, and it's the direction that they have to go in. But I'm a fan of the hospital system, generally speaking, in terms of all the progress that they've made on a lot of fronts. They've really tried very hard, not just the for-profits and the not, but take it all together. They've tried very hard to embrace value-based payments and moving their businesses forward to achieve a different kind of outcome and be participants in the reform process that the law only hinted at. And so I'm a fan of that, and I would encourage that, but I'm highly skeptical of us getting to that almost idealistic state where they finally let go of the paradigm, the business paradigm that they were created for, that they've succeeded with for years and years and years through thick and thin. The mid-'90s was a horrible time for them, but somehow they succeeded to the early 2000s when all their beds were full and they were getting paid out the wazoo, and same-store volumes were growing at 5 or 6% a year. So, that cyclicality of it makes it that the good times will come back, makes it really hard to give up the potential that the good times come back. So I'm very cynical, which shouldn't be a surprise to anybody.